I have a great pleasure to introduce one of the promising anesthesiologists, becoming one, Dr. Ahmed Elsawy, at the MRCP, European Diploma of Intensive Care, Master Degree of Anesthesia, Lancashire Teaching Hospital Trust, UK, the Egyptian. He has a MBCH Cairo University, Egypt, Master Degree Intensive Care in Ain Shams University. Please. His valuable topic today is about the pharmacology of anticoagulant. Yes, Dr. Ahmed.
Thank you, Dr. Safa. It's my honor to be involved in this talk with incredible group of professors. So my talk today, it's almost purely academic. I hope it will not be boring, but it's very important, as Dr. Yasser has presented a clinical scenario which everyone could face in reality. So I'm going to talk about pharmacology of anticoagulants. So learning objectives, sorry, I will just revise this one. Yeah. So to explain types of anticoagulants, to understand the mechanism of action of these drugs, pharmacokinetics and pharmacodynamics, and the role of anticoagulants and their uses, and to highlight the adverse effects of anticoagulants, with some of them have already reversal agent and some not. So classification of anticoagulants, there are multiple classifications. You can classify anticoagulants depending on the mechanism of... sorry? So you classify anticoagulation, multiple classification could classify it as oral or parenteral, or depending on the mechanism of action. So the anticoagulants generally, whether they interfere with the synthesis of coagulation factors or interfere with the action of coagulation factors. So we have, like on the right side of the screen, a vitamin K antagonist, and the father of them is a warfarin, and heparins and heparinoids. We are almost using sorry, Dr. Saad, are you talking to me?
Go ahead.
Do you hear me?
Yeah, I do hear you. Thank you. Go ahead.
Okay. So we have heparins and heparinoids, such as unfractionated heparin, which is still widely used in our units, and low molecular weight heparin, such as enoxaparin, dalteparin, and tinzaparin, and fondaparinux. Direct thrombin inhibitors, we have like intravenous bivalirudin and lipyridine and algatropan intravenous, and the oral drug like dabigatran. And new oral anticoagulant or novel oral anticoagulants, which are direct factor 10 inhibitors, such as apixaban, edoxaban, and rivaroxaban. So just to refresh your memory with unfractionated heparin, it's glycosaminoglycans. It has like wide range of molecular weight, an average about 15,000 Dalton. The mechanism of action of unfractionated heparin, it acts mainly through antithrombin 3 complex, and which in turn forming antithrombin heparin antithrombin complex that attach to thrombin and cause and stop activation, stop its action. And you see on the right side of the screen the heparin, unfractionated heparin, mainly inhibit the thrombin and factor 10 through the antithrombin complex. The heparin also inhibit factor 9, 11, and 12, but the main action of it on thrombin and factor 10. It has another ways of action. It acts as a catalyst through heparin cofactor 2, and it has a modulation. It causes some modulation of factor 10 generation, but to do this, it needs to be a very high concentration, which is clinically insignificant because it's not practical. Pharmacokinetics behind unfractionated heparin. Heparin, we don't see unfractionated heparin orally because it doesn't cross membranes. It is not absorbable, and it doesn't cross placenta, so it's safe in pregnancy. It is highly bound to proteins, which means it gives it a range of and the variability of pharmacokinetics. Metabolized by reticuloendothelial system in circulation. It doesn't have any renal renal excretion in unchanged formulation, so no dose adjustment in renal impairment and can be used safely in a renal impairment patient. The main adverse effects of heparin, of any anticoagulation, first, hemorrhage, and heparin is the commonest drug that can cause heparin-induced thrombocytopenia, and heparin itself can cause hypotension, especially when we give it in theater. Sometimes the bolus and vascular surgery can cause hypotension, osteoporosis with prolonged use, hyperkalemia, and heparin resistance, mainly due to deficiency of antithrombin 3. So compared to unfractionated heparin, we are widely using low molecular weight heparin, such as enoxaparin, dalteparin, and tenzaparin. It's a natural, derived from heparin by depolymerization. It's in low molecular weight, its molecular weight average 5,000 Dalton. Advantages over unfractionated heparin, that in subcutaneous injection, it's better absorbable than the heparin, so it has also a predictable pharmacokinetics. Less effect on platelets, reduced risk of HET, or heparin-induced thrombocytopenia. It causes already, but it is less risk than unfractionated heparin, and reduced need for monitoring. But we need monitoring for low molecular weight heparin in some patients, as in very obese patients, or in some patients with renal impairment or risk of bleeding. Mechanism of action of low molecular weight heparin. In the bottom of left side of the screen, you could see low molecular weight heparin has almost 1/3 the length of unfractionated heparin. It combined to antithrombin, and it formed the antithrombin complex that inhibit factor 10. It has also an action on factor 2, but its main action on factor 10. It's about 4 to 2 in action. So on the right side of the screen, it's brief comparison between unfractionated heparin and low molecular weight heparin. Absorption from subcutaneous injection is better with low molecular weight heparin, and bioavailability is higher with the low molecular weight heparin. Half-life of unfractionated heparin is about 1 to 2 hours, with average 1.5. In low molecular weight heparin, it's 3 to 12 hours with normal renal function, and half-life is prolonged in renal impairment. Unfractionated heparin metabolized mainly by reticuloendothelial system, and low molecular weight heparin has a fraction that renally excreted. That's why it requires dose adjustment in renal impairment, and there is some advice to avoid it if eGFR less than 15. Both are safe to be used in pregnancy. Monitoring, ideally, unfractionated heparin should be monitored by anti-factor 10 level, but most of units, critical care units, have a target of partial thromboplastin time, with targeting 1.5 to 2.5, and they have different units have the protocol for adjustment of the heparin infusion dose according to the PTT. But low molecular weight heparin is targeting anti-factor 10, and because it will be measured 4 hours post-dose, because the Cmax, or the highest level flow molecular weight heparin, about 4 hours post-injection. Antidote of or reversal for unfractionated heparin will be protamine in about 1 milligram for every 100 units. Low molecular weight heparin, protamine can cause partial reversal, roughly about 60%. Heparin-induced thrombocytopenia, one of the complications that could happen from using heparins and low molecular weight heparins in the intensive care units. It occurs about 5% of patients who were exposed to heparin, but it carries a mortality of 30%. It could cause widespread thrombosis and consumption of platelet. The mechanism of the head is the immune head, or the type 2, because we have two types. Type 2, which is the immune one, heparin bind to platelet factor 4 and causing heparin platelet factor 4 complex that in turn will bind to immunoglobulin G, and this complex will attach to Fc receptors on the platelet, causing triggering platelet activation, which in turn will cause like loop activation of the cycle and release more platelet factor 4, and so the cycle will continue and it will lead to consumption of platelet and widespread thrombosis. So we have type 1 and type 2. Type 1 usually happens. Usually it happens 1 to 4 days after you starting heparin, but type 2 typically between 5 and 2 weeks. And type 1 is non-immune, and type 2 is immune mediated. Type 1 usually it's benign and you don't need to discontinue heparin, but type 2 you need to change heparin to one of other agents like direct thrombin inhibitors or fondaparinux. So back to it, there is a 5T score system that we use to evaluate the probability of heparin-induced thrombocytopenia in each patient. Fondaparinux is one of the synthetic, it's chemically related to low molecular weight, but it's chemically related, but it is different in structure. It is synthetic pentasaccharide. It selectively inhibits factor 10 through antithrombin 3. It has longer half-life, 17 to 20 hours. It's elimination in the body dependent on renal clearance, so it's better to be avoided in case of eGFR less than 30, also in elderly patient, and in low body weight below 50 is better to be avoided. The main adverse effect of fondaparinux bleeding, there's no specific reversal to fondaparinux, but still protamine could help in reversal. And fondaparinux, as we said earlier, it is less likely to cause heparin-induced thrombocytopenia. It can be used for prophylaxis and treatment of venous thromboembolism and pulmonary embolism and myocardial infarction. Moving to direct thrombin inhibitors. Direct thrombin inhibitors, they have direct action on thrombin or factor 2A. Not dependent on cofactor or antithrombin 3 levels. So they also less likely to cause HET, so can be used if there is a patient suspicious or at risk of HET, so they can be used. Predictable pharmacokinetics, short half-life. If we're using the intravenous direct thrombin inhibitors, they have shorter half-life. And the parenteral still there's no optimum reversal agent for direct thrombin inhibitor. There are different ones of direct thrombin inhibitors intravenously. This is a comparison between them, lipyridine and desirodine and bivalirudine and argatropan. Maybe bivalirudine can be used in ECMO circuit, on ECMO circuits, and in patients at risk to develop HET who is going to PCI. Algatropan can be used in case of a patient at risk of head as well if he's going to PCI. I will not go through everything on the slide for the sake of time. However, you will notice that plasma half-life it's short. Bivalirudin is about 25 minutes, and algatropan is about 45 minutes. And metabolism is of them dependent on lipirudin, dependent on renal excretion, and algatropan dependent on hepatic excretions. So cautious to use algatropan in patients with liver failure, and cautious with bivalirudin in patients with poor renal functions. So to summarize the comparison between parenteral anticoagulants, we have unfractionated heparin, we have low molecular weight heparin, fondaparinux, algatropan, and bivalirudin. Mainly what you need from the comparison, because it's detailed comparison, you need to know at least the half-life of them. So unfractionated is about 1 hour, low molecular weight 3 to 6 in one resource, and another resource is up to 12 hours. It depends also on the renal function. Fondaparinux 17 to 21, algatropan 45 minutes, bivalirudin is 25 minutes. Regarding the monitoring, unfractionated heparin, antifactor 10A and PTT, low molecular weight heparin, antifactor 10A, but not routinely we monitor low molecular weight heparin unless, as we said earlier, there is an indication for patient at risk of bleeding. Fondaparinux, antifactor 10A can be used to monitor fondaparinux, algatropan, PTT, and bivalirudin as well, PTT. Risk of head higher, the highest with unfractionated heparin, less risk with low molecular weight heparin, but in case of patient has suspicious of head or 40 score show the high probability of head, then we will change to other agent like direct thrombin inhibitors or fondaparinux. Dabigatran etoxalate is a direct thrombin inhibitors, but taken orally. It's a prodrug. It is converted into dabigatran. Bioavailability is 6 to 7% and decreased by using proton pump inhibitors. One third of the drug will be bound to plasma protein. It is metabolized in liver and elimination in biliary, mainly renal 80% and biliary in 20%. Half-life 12 to 14 hours. It can be used to prevent venous thromboembolism after heparin replacement, and treatment of venous thromboembolism and prophylaxis and prevention of stroke and thromboembolism in non-valvular atrial fibrillation. Because elimination, it depends on renal excretion, so dose adjustment in renal impairment is required, and it's oral drug, and it doesn't need to be monitored. In case of serious bleeding happen, so either eculizumab can be used for reversal, but I know it is very expensive and not available everywhere. And it has some drug interaction, so like amiodarone and verapamil, so you need to pay attention to drug interaction. So novel oral anticoagulants or direct factor 10 inhibitors, such as rivaroxaban and apixaban. So these drugs on the right side of the screen, you will see that as a site of mechanism of action. So they inhibit, activate factor 10 and prevent thrombin generation. Also, as Dr. Yasser said earlier, the more action of them, especially on platelet as well. So it's not only as an anticoagulant, pure anticoagulant. Metabolism mainly in liver. So caution with cytochrome P3A4 inhibitors, which potentiate the action of these drugs. Elimination of the NOACs is mainly renal. About third of the drug it's excreted and changed in urine. Half-life is about 12 to 14 hours. So they are approved for usage in prophylaxis and treatment of venous thromboembolism and pulmonary embolism, and to prevent stroke in non-valvular atrial fibrillation. Rivaroxaban as well is used for prevention of thromboembolic events in case of patient with coronary or peripheral artery disease. Adnexonate alpha is licensed for reversal of apixaban or rivaroxaban, but in case of serious bleeding, still prothrombin complex and FFP can be used. It will help. So this is a comparison between the oral anticoagulants, comparing apixaban, rivaroxaban, edoxaban, and dabigatran. So mainly just to pay attention to the metabolism. You will find rivaroxaban is dependent on cytochrome P, about 30% on cytochrome metabolism. So it's very important to pay attention to drug-drug interaction in case of rivaroxaban. Apixaban less 15%. Half-life of the drug, apixaban about 8 to 15 hours, rivaroxaban 9 to 13 hours. Edoxaban 10 to 14. To be honest, I didn't see edoxaban in clinical reality. I don't know if you have experience with it. Dabigatran is half-life about 12 to 14 hours. Renal elimination is dabigatran is the highest dependent on renal excretion, is about 80%. So it's very important to check renal function before prescribing it. Warfarin, we know the one of the oldest indication of anticoagulation is warfarin. Warfarin acts as anti-vitamin K, or it blocks the synthesis of vitamin K dependent clotting factors, factor 2, 7, 9, and 10. It mainly works to preventing the conversion of the vitamin K into oxidized form. So it will reduce the carboxyglutamyl residue that is required for active clotting factor 2, 7, 9, 10. So to produce its action, so it is not, warfarin will not affect the already formed coagulation factors, but it will affect the synthesis of the coagulation factors. So its action will be apparent at least about 72 hours to 96 hours. It is completely absorbed from gut. It is highly bound to plasma protein, about 95%. It's very important to understand if you are giving something to displace the warfarin from protein binding, so the drug will be, it will potentiate the action of the drug. It causes the placenta, half-life about 40 hours, metabolized in liver with cytochrome P of 450 into inactive metabolites, and excreted in urine and feces in inactive compounds. Monitoring mainly by INR, targeting INR 2 to 3 in most indication, but in some mechanical valves like mitral needs a higher 2.5 to 3.5 targeting INR. So warfarin is it's widely used for prevention and treatment of venous thromboembolism, such as DVT, deep venous thrombosis, and pulmonary embolism, and prevention of thromboembolism in atrial fibrillation, aromatic or prosthetic heart valves, antiphospholipid syndromes, and protein C and S deficiency. It also licensed to be used in prevention of venous thromboembolism in orthopedic and gynecological surgery. Despite we are not commonly using nowadays warfarin in those patients, but because we have alternative already. Adverse effects mainly hemorrhage, teratogenicity. It is not for a pregnant woman. Skin necrosis, purple toy syndrome, because it depends mainly due to spread of atheromatous plaque distally and cause bluish toys and like distal ischemia of toys. Drug interaction, it has very wide drug interaction. So metabolism dependent on cytochrome P450. So there are lots of drugs can potentiate warfarin action and increase INR. So pay attention to drug-drug interaction. Reversal of warfarin-induced bleeding. It depends on how serious is the bleeding. So if it is life-threatening bleeding, we used to give prothrombin complex concentrate and vitamin K intravenously, and you give FFP. If there is just INR, but to correct INR, so we are moving toward giving vitamin K and omit warfarin dose. And reduce the following doses of warfarin and careful monitoring for the INR. So just to summarize the mechanism of action of anticoagulants in this slide, I feel it's a brilliant slide for me because it summarizes the action of different drugs. You see heparin and fondaparinux and low molecular weight works through antithrombin 3. You see, antithrombin 3, fondaparinux and low molecular weight works mainly on factor 10A. Heparin works and low molecular weight on factor 2A. You will see direct thrombin inhibitors, Rivaroxaban, Apixaban, and Edoxaban, and working on 10A and reversal andexanate alpha. You will see on the bottom of the right side the direct thrombin inhibitors working on thrombin and the reversal edaroximab. So, learning message. Choice of anticoagulant is multifactorial. It's not depending only the indication, but also you consider patient factors and you consider the comorbidities of the patient. And if the patient is taking drugs, I'm not talking only on giving anticoagulation within the critical care units, even discharging the patient on oral anticoagulation is something serious and need to pay attention to it. Unfractionated heparin is still widely used, and we follow protocols in different, each hospital has a protocol for those adjustments. Unfractionated heparin and low molecular weight heparin could cause heparin-induced thrombocytopenia. So in case if the patient at risk of HET, so fondaparinux and direct thrombin inhibitors, and some resources said also novel oral anticoagulant can be used.
Please, Dr. Ahmed, please.
Yes. It's time. I'm
Dr. Ahmed, please.
So actually, there is no question at the moment, and because of the time, Dr. Safa, I will ask Ahmed just one question, and you can go ahead for the next speaker. Okay, Ahmed?
Yes, sure.
You mentioned about the heparin-induced thrombocytopenia.
Yes.
Okay. If a patient coming for surgery with this problem, whatever, he has bleeding secondary to thrombocytopenia, or he have, for example, intra-abdominal infection or fracture or whatever, how we can immediately manage this thrombocytopenia before coming the surgery or intraoperative? What is our role in this situation?
So I think it is not advised to give platelet at this stage because it will be increasing, it will be consumed. I'm not sure if it's it depends on the situation. About how low platelet is. If the patient has, like, for example, serious bleeding, do you mean serious bleeding, like intra-abdominal or intracerebral?
All right, okay.
So I'm not sure, to be honest, yeah.
Okay, Dr. Safa, you can go ahead. Turn on your speaker.
Thank you, Dr. Ahmed Elsawy. Thank you.